are our patient. So this is the man, Dr. AFBMF Karim, who was an emeritus professor in Free University Amsterdam, who was the founder of this organization, Oncology Club, who founded in 1996. In 2001, he founded the South Asian Federation of Oncologists Forum. And this gentleman first invited AK in 2007, and thereafter the communication with MGH, with Oncology Club, was continuing. In the course of time, initially two young gynae-oncologists from Bangladesh, Professor Shahana and Professor Jannatul, went to MGH and get trained under AK, and now both of them are doing a leading role in our two iconic institute, National Institute of Cancer Research Hospital and our University Hospital, and they are doing great job under their seniors. Thereafter, AK has been visiting in our country routinely, and she was trying to improve our care in the gynae-oncology discipline, and she has witnessed the change in our country, that how it happened. In the COVID era, we had done around 60 virtual program on gynae-oncology, and there were 32 tumor boards where AK was the highest attending physician. In the continuous effort, now we are going to start one with MGH. So today we are honored to have some faculty expert panels from overseas. Dr. Marcela Del Carmen, who is the Executive Vice President, Mass General Hospital, Mass General Brigham, Boston, USA. And then we have Dr. Tom Randall, who is a known person to us because of his participation previously. Tom is a gynecological oncologist and gynecological surgeon, associate professor, Harvard Medical School, Manchester General Hospital, Boston, USA. We are having our old friend, Dr. Annie Catherine Goodman, who is a professor of obstetrics, gynecology, and protective biology, Harvard Medical School, Boston. And also we have Dr. Kyle M. Devins, who is a general pathology consultant in Mass General Hospital, Boston. And also we are excited to have Alexandra Bateau, who is a research fellow in Mass General Hospital. And from here, Dr. Farhana Kalam, who is the qualified gynecological oncologist in our country and had the opportunity to be at MGH as a fellow for a certain period. We're working now as the junior consultant in gynecology department of National Institute of Cancer Research and Hospital, and she will be presenting the case. So now the Oncology Club is running under the leadership of these two men. He's the Secretary General, Professor A.M.M. Shariful Alam, and our President, Professor A.M.A. Hai. So Shahana wanted to finish her slide by saying that supporting the fighters, admiring the survivors, honoring the taken, and never ever giving up hope. So this was her last slide. And with this slide, I want to stop my presentation. I was to ask AK if Marcela want to say some, we'd like to invite Marcela to say a few words from our Western part, and then we will start our program. May I request Marcela to make a comment?
Thank you. Before Marcela does, I just wanted to say thank you so much for that beautiful introduction. And I'm very proud to have Marcela talk for us at this inaugural event. Marcela is someone who is a leader. She is an exquisite gynecologic oncologist. She's a professor at Harvard Medical School, a teacher, and really very much has been in our leadership at Mass General Hospital for many years now, has basically brought us through COVID, and also has a great vision about global health and connections internationally. So I want to turn it over to Marcela, and thank you so much for being here, Marcela. It's an amazing privilege because you are so busy.
Thank you, Ike. So first of all, thank you for allowing me the opportunity to be here with you this morning for us in Boston, and I think afternoon for you in Bangladesh. Before I start, I want to recognize that we have with us Dr. Esther Oliva, who's a professor of pathology and a world-renowned pathologist. Certainly, when I have a question about a surgical specimen, and sometimes even clinical questions, I will ask Dr. Oliva. So Dr. Oliva, thank you for taking the time. It's a real privilege to have you join our tumor board this morning. I want to start by recognizing and thanking AK, who has been a friend and a mentor. I came to the MGH in 1999 because I wanted to become an expert pelvic surgeon, and AK was the reason that I came. She has remained a mentor and a friend and a sponsor of my career, and I want to recognize not only what she's done in my own personal career development, but what she's done to transform the career of many, many surgeons in the United States, specifically women, and for the care that she has offered patients over decades, not only in Boston, but also globally. We are living unimaginable times in medicine and in the world. And I think that never more has it mattered for us to be community and to be able to work across boundaries and to have global medical work. So it is a privilege to be able to offer the kind of support and the kind of care that this partnership will bring to women globally, and we will all learn together. Our patients will be better served. And it reminds me of the mission that was basically the founding principles of this hospital. This hospital was founded in 1811 to serve the poor patients in Boston who could not afford private medical care. And our mission has 4 pillars: clinical care, education, research, and community service. And I cannot imagine a more noble effort to actually accomplish that mission. So from the MGH, I want to thank you for being willing to take the time and take the risk and bring us forward in this partnership. I want to recognize the members of the MGH team that will be part of this collaboration. Specifically Dr. Tom Randall, who has also been a lifetime mentor. Tom was actually my resident. I was a medical student, one of the reasons that I decided to go into USA&Oncology. So it is truly remarkable for me to be in a panel of so many prestigious colleagues and trainees. And I want to kick it off and turn it back over to AK. And again, thank you for allowing us to be part of this wonderful partnership and experience.
Thank you so much, and thank you, Kamal. Should we turn the stage over to Dr. Farhana to present the first case?
Yeah, Farhana, please.
Thanks to the organizing committee of Oncology Club for giving me the opportunity. I am very much honored to be here with all distinguished faculties of Mass General Hospital. Let us begin with the story. Hatia, a remote island of Bangladesh. It is about 238 kilometers far away from Dhaka, the capital of Bangladesh, and communication is not so easy. A 18-year-old girl comes from that place at year 2021 during COVID pandemic with pain and abdominal distension and respiratory distress. She is so helpless. Doctors of NICRH took her responsibilities. They donate blood and money. Finally, laparotomy followed by removal of huge abdominal lump was possible. The size of tumor was about 70 into 40 centimeter and weighed about 40 kg. And final histopathology report was mucinous cyst adenocarcinoma. She was advised for adjuvant chemotherapy, but she denied to receive chemotherapy and went back to her home. After 1 year, she again came back to NICRH with recurrence. We again advised her for adjuvant chemotherapy, but she lost to follow-up. We tried to communicate her for several times, but we couldn't reach her. Actually, we try to do a lot for our patients, but due to poverty, illiteracy, lack of knowledge, superstitions, we are not succeed every time. Now, come back to my case scenario, today's discussion. Mrs. X, 48 years, para 4, living 4, attended to Gynecological Oncology Department of NICRH at 12th April 2022 with the complaints of lower abdominal pain for 3 months and constipations for same durations. She had a history of total abdominal hysterectomy with bilateral surfingophorectomy for ovarian tumor on 8th August 2020, and it happened outside NICRH. Histopathology report shows papillary serous cyst adenocarcinoma low grade, and she received no adjuvant chemotherapy. Here is a pathological slide. And at that time, the patient was in outside NICRH and she was in regular follow-up. But whenever she had problem on 12th April 2022, she came back to us and we examined her, found ECOG performance status 1, anemia, jaundice, edema absent, accessible lymph node not palpable. On parabdomen.
Farhana,
Yes.
I'm so sorry. Could you go back to the pathology slides and maybe Dr. Devins could make some comments?
Okay, I want to finish my case and thereafter I go back to that slide.
Okay, super. Thank you so much.
Thank you. Parabdominal examination and ill-defined firm mass felt in lower abdomen. And pelvic examination, per speculum examination, vault healthy. Per vaginal examination, a firm mass about 8 into 5 centimeter, adherent with vault felt in pelvic cavity. Per rectal examination, nodules felt in pouch of Douglas. Her investigation profiles, all biochemical and hematological reports are within normal limit. Tumor markers, CA125, 340 unit per ml, 1993.12 unit per ml, CEA 1.83 nanogram per ml. Imaging, ultrasonogram of whole abdomen was done, subacute intestinal obstruction with thick gallbladder, enhancing soft tissue area in lower abdomen, possibly colonic origin. And this is a CT scan report which showed hepatic space occupying lesion. Actually, we have CT scan plate. We don't have an image viewer. This is a plate. And final comment is post-TH BLSO state, soft tissue mass 8 into 5 centimeter in pelvic cavity recurrence, hepatic SOL recurrence, no abdominal lymphadenopathy. And we advise for CT guided core biopsy from the pelvic mass, which shows papillary serous carcinoma recurrence. Here is her histopathological slides. Thanks. And now I am going back to the histopathological slide, first one. Okay.
So now I think we can have hear from Dr. Devins.
Sure. Yeah. If we look at the pathology slides for this particular case, we see this nested and micropapillary invasive growth, which combined with the cytomorphology, which looks, although the cells are somewhat degenerated here, looks mostly low grade. It looks consistent with a low grade serous carcinoma. These are distinct from high grade serous carcinoma in middle-aged women. What really makes the distinction here is the cytomorphologic feature. So if we see pleomorphism, numerous mitotic figures, that sort of thing, this would be a high-grade serous carcinoma, but based on the cytomorphology, this fits in the low-grade category. I don't know if you want to add anything.
Can I? So I will agree with what Kyle said, and but I would make the point that sometimes high-grade serous carcinomas can have this low-power architecture where you do have like these free-floating nest or papillae, you know, in these empty spaces. So it's really important to look at, as Kyle mentioned, at the cytomorphology, so the cytologic features of these tumors. And it's also important to sample, you know, extensively these tumors to make sure there is not really a high-grade component, because as I said, there's times where you can actually see kind of hybrid features. So from what we see here, as Kyle said, this is consistent with low-grade serous carcinoma. I don't know if in your place you actually do have immunohistochemistry, for example, and potentially one could perform a P53, which is a relatively, widely used immunostain. And if you could, and if it actually shows what we call a wild pattern of staining, that also would support that you actually have a low-grade serous carcinoma.
So I
Thank
wonder
you.
if
I want to see the next histopathological slide of these cases. And this is her now pathological slides after core biopsy.
We don't see any. Oh, here we
Oh,
are.
here it is. Here it is. Oh, okay. Yeah.
Uy.
So here we can see the tumor involving the hepatic tissue, which is that kind of pink, more homogeneous tissue that you see better on the right side. The growth here from this particular power, we're just seeing this solid and cribriform growth of cells, which you could see in a high grade or a low grade serous carcinoma. But again, we'd have to see a higher power image just to make sure that the cytomorphology fits. But assuming it's consistent with the last, yeah. If it was consistent with, if it was the same as the last one, it would be consistent with a low grade, but you'd really want to look closely at this and rule out high grade cytomorphologic features at higher power. Yeah, it's worrisome.
This solid growth pattern is actually worrisome for a higher grade lesion. You know, that's why I think it's really important. Yeah, I mean, it's.
This
I don't know.
Yeah.
I wouldn't go like over it with this growth pattern.
Yeah, it worries you.
To me, it's worrisome for higher grade lesion.
Yeah, it's a bit of overlap.
That's not the group that you actually should see.
So Dr. Farhana, so putting this all together, this is a young woman who has a recurrence in her liver that looks high grade on the second pathology. Would that be a good summary?
Yep.
So just opening this up to our discussants, Dr. Marcella and Dr. Tom and Dr. Kamal, what are your thoughts about next steps for this patient?
So I think, AK, it will be great. We hear from Marcella that what has been done, because we already heard that there was an opportunity to do a P53 immunohistochemistry, probably it was not done. So it was a good information for us that we can carry, that when there are something like this, we can do P53, which can help us to identify it's to reconfirm the diagnosis, rather I will say the type. So what we have done till now, I mean, what could be done? Can we hear from Marcella or Tom? Okay.
Pausing, not hearing Marcella yet. I'll go ahead, Kamal. Thank you so much. I think this is a fantastic example of the paramount importance of high quality pathology in guiding our management in GYN oncology. You know, we have this doubt of whether this is high grade or low grade. We think that Dr. Devens, Dr. Oliva tell us that a P53 immunohistochemistry, as well as probably further careful review of just the H&E, can give us a better idea of whether this is high grade or low grade. For me as a clinician, that's vital. And we have a whole pattern of practice in ovarian cancer informed by clinical trial data that is largely based on high-grade serous ovarian cancer. And so the idea that now we try very hard to avoid surgery, particularly in the recurrent setting, unless we can do a complete surgical cytoreduction. So no visible or palpable residual disease. As I say, this is based on high-grade serous ovarian cancer, and the goals of and participants, please remember to mute yourselves unless you're speaking, if you could, please. But the low-grade serous ovarian cancer, as I think most of the audience knows, is typically less responsive to chemotherapy and more slowly growing. Not, you know, can't always be both of those things, but so for me, with a low-grade serous ovarian cancer, two things become more important. One is the possibility of using hormonal therapy for this woman, particularly if she's reluctant to take multi-agent chemotherapy. And the second is that I think there are times where a less than complete surgery may be very helpful for the patient's quality of life with a low-grade serous ovarian cancer. So I'm interested in how symptomatic this woman is from the pelvic disease, because it's possible that resection of the pelvic cancer, even if the hepatic lesions are not resectable, would be valuable. Interested in AK's thoughts about that.
Yes, thank you.
Whenever you are going to make a comment, I would like to ask you that the surgery, we can see that it was not a complete staging done. So Tom has touched upon that point. I will request that when you will cover that part also. Thank you. Okay, please.
Oh, sorry. I was going to say I agree with Tom, and I believe that Dr. Marcella has had to leave to go to another meeting. I think I don't see her on this. Marcella, let me know if you're here. But she was so kind to come for the beginning. I also wanted to say that our colleagues in medical oncology here regretfully have a very important meeting at this time and cannot make it, but the head of that group, Dr. Castro, reviewed the cases and gave me some comments to give. His comment on this case was that he would recommend going with carboplatin and Taxol as the sort of next step in treatment for her. So I just wanted to put that out there. I mean, I think that the issue of pathology is key, and having our pathologists really carefully review really guides us. I noticed that Dr. Lutfa has put a comment in the chat about is this really progression of disease after chemo? And that's a very, very good question. It sounds like it kind of is. Am I understanding that correctly? Kamal and Farhana?
Farhana, was there any chemo given to the patient? I don't think so.
No.
So there was no chemotherapy given.
As her report was low grade, so patient.
So she was kept on observation.
Yes, but during observation period, she developed recurrence.
Okay,
So,
good. Okay.
So, we have few issues. Whether it was a correct decision to keep her on observation, considering as a low grade, this is number one. Whether the surgery was inadequate, number two. Whether we could have given some chemotherapy at the beginning, which could have prevented this metastasis. Because now we are standing at a situation where the patient has metastatized to liver. We are sure about it. But initially, considering as a low grade, and we didn't give her, the patient was not given any adjuvant chemo. And you can see that we can appreciate that the comprehensive staging was not done also.
Yeah.
If I can say something, I mean, to me, as you said, the original issue is this really a low grade? I mean, I wanted to ask the two of you, Tom and AK. I mean, I don't think a low grade would recur massively after a year, right? I mean, I actually think that this is a bit unusual, and as I said, sometimes, high-grade tumors can have a low-power architecture that's kind of similar to low-grade tumors. So I think thanks for highlighting the importance of pathology, but I truly think that everything could go wrong, right? If we have called this thing low grade, and in fact is a high grade, and then it wasn't treated, and it should have been treated, you know what I'm saying? So that's what I mentioned, the P53, which it has its problems, its intricacy, but if it works well in the laboratory, and it shows what we call a diffuse pattern of staining or a complete lack of staining with a good internal control, that would help you to decide that also this is a high-grade serous carcinoma.
Yes, I thank you so much for those comments, Dr. Oliva, and ultimately, to the point of Kamal and Tom, interventions with surgery in low grade are key. And so we do think about as comprehensive interventions as possible as primary therapy. After surgical excision to the maximum that one can do, the next step really is going to depend on pathology. However, having said that, I do believe our standard would be, even in a low-grade advanced serous cancer, to give adjuvant therapy with carboplatin and Taxol and not to follow. We may, after 6 cycles of adjuvant therapy, think about perhaps a selective estrogen receptor modulator such as tamoxifen or anastrozole or something like that, if it had ER/PR positivity. But there's some support for doing that sort of maintenance therapy in the setting of an advanced low-grade cancer. In a high-grade cancer, after primary carboplatin and Taxol, you do nowadays think about maintenance with a PARP inhibitor based on genetics, but that's a separate story. So to summarize this, because I know you have another case, pathology is very important. I think to Esther, Dr. Oliva's and Dr. Devon's points, pathology is helpful to an extent, but behavior ultimately rules, right? So for this patient, she's behaving like a high-grade cancer, right? And liver metastasis is extremely unusual in low-grade cancers, I think, unless there's other comorbidities, such as severe immunosuppression and other stuff like that. So primary cytoreductive surgery comprehensively, really good pathology analysis, combination chemotherapy, and then maintenance depending on the histopathological setting. Now with liver metastasis, you definitely would start with chemotherapy. This is Dr. Castro, our medical oncologist's recommendation as well, and then reevaluate based on response for surgical intervention. I was wondering if there were any last comments before going to the second case.
So AK, I think it was a wonderful summary and good comments. So I have 2 points. Say, as you said, in the advanced low grade. So whenever, because you know the rule of thumb, low grade surgery observation, high grade go for chemo. But now we are considering all low grade doesn't behave always as a low grade. And shall we do immunohistochemistry in all low grade? That is my first question, P53, to the pathology colleagues, because we cannot appreciate the behavior unless we see the time frame. Another is, when we will consider that even in a low grade, what will be the criteria to decide that this is surgical intervention is not fair enough? We need to add some chemotherapeutic agent in some low grade. What should be the criteria for our junior colleagues that will guide them to decide, well, hey, all low grades are not low grade, number 1. Number 2, shall we go for P53 for all low grade? These 2.
I think if there are some cases where the cytology is very uniformly bland, or uniformly bland, I guess, yeah. And in those cases, I don't think you have to do P53. We, for example, don't do it on all cases that we think are low grade. But there are some where, in some areas, the nuclei start to look a little bigger, start to overlap. And in those cases where it's kind of by H&E on the borderline, especially if there's some mitotic activity, in those cases we do often do P53 just to confirm our impression on the morphology.
I think again, sampling is also important. You don't want just to take 2 sections of the tumor. You want to actually have a thorough sampling of the tumor before you even do the P53. So we also always emphasize this thorough, pathologic sampling in order to actually find you know, the characteristics of the tumor, right? So, because as Kyle said, there are tumors that, you know, in some areas can look low grade and in other areas may look a little higher grade. So if you already have sampled it, you don't need to do the P53. But in cases where you are not sure, where, you know, then P53 can help. But again, you have to be aware of the patterns of staining of the P53. You need to be aware of the pitfalls that can happen with P53 staining. You have to have a reliable laboratory where you actually know that the P53 is working properly, because there are also examples where, you know, this antibody may be misinterpreted. So again, it's all about the context, right?
That's a wonderful summary. In the interest of time,
We go to
Dr.
the
Farhana.
next
Oh, I'm
So,
sorry.
okay, would you like to go to the next case, because we need to finish on time?
Yes, please. Let's go to the next case. Thank you.
So, okay, Farhana, can you start the second case? Because this is a never-ending discussion. We cannot finish the discussion. So if anybody have a question, they can put in the chat box and our faculties will be responding to them.
Welcome back to my second case. Mrs. X, 50 years, para 5, living 3, admitted to National Institute of Cancer Research and Hospital with the complaints of lump in abdomen for 6 months, anorexia, nausea, and weight loss for 6 months. Examination findings: ECOG performance status 1, anemia positive, accessible lymph node not palpable. Per abdominal examination, a huge mass about 18 into 20 centimeter with irregular surface and restricted mobility, partly solid, partly cystic in consistency, occupying umbilical, both lumbar, hypogastric region. Pelvic examination: per speculum examination, cervix apparently healthy looking. Per vaginal examination, hard mass with restricted mobility filled through all fornix. Per rectal examination, rectal mucosa free. Investigation profile: all hematological and biochemical parameters are within normal limit. Tumor marker CA 125/70 unit per ml. CA 99 is here high, 23,891 unit per ml. CEA 3.11 nanogram per ml. And we do imaging. Here is the CAT scan plate. Here shows a huge mass. And the report is a huge, sharp, marginated oval soft tissue density mass is seen in abdominal cavity. It measures about 24.8 into 22 centimeters. It occupies right hypochondriac, epigastric, and both lumbar regions. It displays bowel loop peripherally. And the impression is huge intra-abdominal mass, minimal ascites. Her endoscopy, colonoscopy was normal, X-ray chest view normal. And our treatment plan was laparotomy with frozen section biopsy followed by surgical staging. And the frozen section report was positive for malignancy. Here is our surgical field video. Lower midline incision is given here. And the incision is extended upwards liberally to prevent rupture or spillage of tumor. The mass was removed first and then sent for frozen section. Frozen report was positive. So we did bilateral, total abdominal hysterectomy with sulfingophorectomy, both-sided pelvic and para-aortic lymphadenectomy and omentectomy. Yes, here is the mass and it comes out. So this is the picture of that mass. And that patient at 6 post-operative days, the wound looks healthy. And this is our histopathological slides.
Yeah, so
And,
the
sure.
we see here these atypical cells with apical mucins. This is consistent with a mucinous adenocarcinoma due to the complexity of the architecture as well as the atypicality of the cells. And whenever we see a mucinous carcinoma, we always want to make sure that we're ruling out a metastasis as well, because in these particular slides, what we're seeing is compatible with a primary ovarian mucinous carcinoma, meaning it's invading in sort of a pushing pattern rather than a destructive small nest of infiltrating cells, which are something that you more often see in metastasis than in primary tumors. This expansile type of growth pattern is what you see in most mucinous adenocarcinomas of the ovary. But these are another tumor, Dr. Oliva earlier was talking about sampling. Mucinous tumors in particular, we always try to sample very well because they often have a range of morphology within the tumor. Even in adenocarcinomas, they often have areas that look bland and by themselves. If you were only looking at that area, you would say this is a benign cystadenoma. And then they often have other areas that look borderline, and then other areas that show this expansile growth and these more atypical areas consistent with carcinoma. So we always encourage you to really sample these tumors particularly well. And we often will even take, our usual rule of thumb for tumors is about 1 section per centimeter of tumor, but for mucinous tumors, we often take 2 sections per centimeter, and that's greatest diameter of tumor. So say a tumor is 20 centimeters in greatest dimension. If it's a mucinous tumor, we would often take 40 sections of that tumor just to make sure we're getting a really good idea of the morphology.
I think actually what Farhana mentioned, prior to this intervention, I mean, and as Kyle mentioned, metastasis, is very high, in the differential diagnosis. In fact, in the past, many years ago, we would say, stage 3 mucinous carcinomas of the ovary, right? And we realized over time that these stage 3 mucinous carcinomas of the ovary in reality were metastatic colon cancer, metastatic gastric cancer, or pancreatic cancer, metastatic endocervical carcinomas, metastatic appendiceal carcinomas, because primary mucinous carcinomas of the ovary, most of them are stage 1 at the time of diagnosis. And this is why we also encourage, to look at the surface of the ovary, make sure there is no other deposits of tumor outside the ovary. And because if you see these features, you should really suspect that you are not dealing with a primary mucinous carcinoma of the ovary, but rather a metastatic carcinoma also if the tumor in the ovaries is bilateral, right? So there are a set of features that would make you think metastasis. And we often, AK knows especially, that we'll call back and I'll say to her, did you look at the colon, right? Did you check the appendix? Especially when tumors are bilateral, tumors have surface involvement, there's tumor outside the ovary, because as Kyle said, metastases are much more common than actually primary mucinous carcinomas of the ovary. But I agree that this one looks like a primary one.
Yes, this is our surgical staging was stage 1A. And our report is final histopathology report is mucinous adenocarcinoma moderately differentiated. And thanks all for the patience here.
Yeah. So that is a fantastic presentation, Dr. Farhana, and your surgical skills. I am just amazed, just your wonderful, wonderful surgical skills. All of you do so many surgeries in your hospitals in Bangladesh. Back to this histopathology, and actually one of the questions that Dr. Kamal brought up was that she has a very preoperatively elevated CA19-9. And, you know, while we think of that as being a GI tumor marker, it can also be seen in mucinous ovarian cancer. So Dr. Aliva, your comments about really being careful to try and distinguish are very, very helpful. And just to ask, the issue of sampling is really important, but in a setting where something turns out to be a GI primary, do you actually see something this large on the ovary? Or is this having such a large ovarian tumor makes you think it's unlikely to be a bowel primary?
There is a kind of a rule, some rules, but the rules are not 100%. But I think, okay, your point is well taken. Typically, we say if a tumor is more than 10 centimeters and unilateral, that would favor a primary ovarian mucinous carcinoma. But this actually is not holding very much true when you actually have metastatic endocervical carcinoma, metastatic appendiceal carcinomas, or actually small bowel carcinomas. But in general, bilateral tumors less than 10 centimeters, that goes for metastasis, right? But you want to apply also the other criteria that we mentioned. Unilateral more than 10 centimeters will favor, as AK mentioned, primary tumor in the ovary.
Thank you so much. There are a few questions that Dr. Kamal sent. Maybe if we could briefly cover them. Dr. Burkow has a presentation. It's not on ovarian cancer, it's on immunotherapy in cervical cancer. But just to finish this first inaugural session with a small didactic, I want to give her that space. But I just wanted to go over a few of the questions that I think are really interesting related to case number 2. The first one is there a role for immunohistochemistry in this case in helping you make this diagnosis, Dr. Devon?
We sometimes use immunohistochemistry. The problem is there are certain things that can help and some things that don't. So if the tumor was, for example, positive for PAX8, that supports a GYN primary, although it could also be positive in an endocervical carcinoma metastasis. However, the problem is many primary mucinous carcinomas of the ovary don't express PAX8. They are, so in many cases, it doesn't help one way or the other. We can also use keratin 7 and keratin 20. Those are other sort of classic immunohistochemical stains that can help. Primary mucinous carcinomas of the ovary are usually CK7 positive, but unfortunately, sometimes they can also express some CK20. If it was, say, positive for CK20 strongly and negative for CK7, that would be worrisome for a GI metastasis. So some patterns like that can be helpful. There are other more specialized stains for other sites, and going into each one I think would be a bit too much. But I think those are some basic stains that can help in some settings. But again, because of the patterns, you really have to combine it for the morphology for this particular tumor type.
Thank you so much. And Tom, I'm going to have you answer this question, if you're still there, which is, would we do BRCA testing for a mucinous tumor, and what's the yield on that?
Yeah, that's a great question, isn't it? We are testing all of our women with epithelial ovarian cancer for BRCA mutations. We do germline testing. And then if that's negative, we go on and do additional testing, including testing the tumor for something called homologous recombination deficiency, or HRD, we call it, because that is also predictive of sensitivity to PARP inhibitors. And that's going to be a discussion for another oncology club. But so we would test her, and we think that the yield would be lower than it would for a patient with a high-grade serous ovarian cancer.
Yes, I agree. So I actually I think we routinely get a genetic testing, but hold on. But say you had a resource limited environment where you had only so much money to spend, right? And we know that testing can be expensive. Given the mucinous histology, would that be a reason to say, you know, if we're just going to play the odds, it's unlikely that BRCA testing would help, and maybe we could use this money in a better way? Or would you still routinely get it on all histopathology subtypes in ovarian cancer?
Yeah, fantastic question. I agree with your implication, AK, that I would forgo BRCA testing depending on limitations of resources for these women, particularly with a really early stage mucinous carcinoma of the ovary. This woman has a reasonably low risk of recurrence. As I put in the chat, NCCN would recommend observation for this woman, and she has a high chance of long-term survival. So I think, in addition, AK, to your point, there is less need for testing because she has a lower chance of needing further therapy down the line. So what's actionable about getting BRCA testing in a woman who may not recur? Well, you know, evaluation of her offspring, et cetera, and other family members. But that's sort of a question for another day and potentially a higher resource setting.
Wonderful. Well, one more question so that then Dr. Burkow can teach us to finish this beautiful session. I would like to introduce very proudly our graduating senior fellow, Dr. Lauren Philp. She's waving at you there. She is amazing. She is finishing her 3-year GYN-Oncology fellowship and she's from Canada and will be moving to Toronto to take an academic position there at Princess Margaret. Is that right, Lauren?
Yep.
And I wanted to ask her to maybe kind of close this session with comments about adjuvant therapy in the setting of a stage 1A grade 2, excuse me, grade 2 mucinous, sorry, that's my beeper, mucinous adenocarcinoma of the ovary. Dr. Philp, what would be your recommendation for this patient for our colleagues in Bangladesh?
So you have to admit, I was filling up my coffee, but I think I heard Tom say that it was early stage. So stage 1A, I think it was confined to the ovary. So, you know, I think like Tom said, you know, if it's stage 1A or 1B, NCCN guidelines would say that patients just need observation, do not need any adjuvant therapy. Stage 1C and above, they do recommend adjuvant therapy. That being said, I know that there's other guidelines from ESMO that take into account the histologic look of the tumor. So we know there's the 2 subtypes, there's expansile and infiltrative, and they sort of subdivide those early stages more and say that if anyone, even if they have a 1A or 1B and they have an infiltrative look to their tumor, they recommend adjuvant therapy. Whereas if you have an expansile 1A and 1B, they don't recommend. So, you know, depending on which guidelines you actually decide to follow, and we usually use NCCN. If you think that your patient needs chemotherapy, really they sort of leave it up to the discretion of the treating physician. You know, you can use carboplatin and paclitaxel, like a normal ovarian regimen. You can also use a GI regimen. So you can use capecitabine and oxaliplatin, or you could use FOLFOX, which is 5-FU, oxaliplatin, and leucovorin rescue. You know, there's also the question of adding bevacizumab. I think that people may not do that for stage 1, but may consider that for patients with more advanced disease. Dr. Penson, actually one of the medical oncologists here, was on a trial that I think was GOG 241, which looked at comparing carboplatin paclitaxel to capecitabine oxaliplatin, and unfortunately they weren't able to enroll enough patients to draw any firm conclusions. The study was really underpowered. But what they did see, even in this underpowered study, is that the curves really seem to separate with favoring the GI regimen. So I know here that we say, there's no significant difference between those two regimens, and I think we're more comfortable giving carboplatin paclitaxel. So I think a lot of times we do give that, but I think you would also be very correct to give them a GI regimen. So I don't think there's a right answer. I think NCCN leaves it up to you.
Yeah. So maybe just to finish, thank you. That was a wonderful set of comments that we'll have to digest. Dr. Kamal, given these comments, how do you think you'd like to treat this patient? Dr. Kamal is the medical oncologist who would be giving chemotherapy.
Yeah, AK, I feel tempted to give some chemotherapy, but as Tom said, that all the evidence are not in favor of giving her any chemotherapy. Even in a very scary mind, I will be keeping her on observation. But to be very honest, to keep a patient like this on observation, need a big courage in our country. But to stick with the evidence-based practice, I will be offering her observation. But I will be counseling her that she needs to be on real follow-up.
Wonderful. I want to thank everybody and our pathology colleagues. It's so exciting to have you at this first inaugural conference, and hopefully with our every 6-week schedule, we can include you and learn from you in this manner. I wanted to turn it over to Dr. Burkow now, who is finishing her first year of fellowship in gynecologic oncology. And she has spent the year teaching us every week through our journal club about clinical trial work and its relevance to how we treat our patients and what our standard of care comes from. And she's going to teach us now for the next 10 minutes to finish our session.
Thank you, AK. I'm just going to share my screen. Give me 1 second. What just happened to it? Okay. Can everybody see my slides okay?
Yeah, it's fine.
Great. Okay, so my name is Alex Burkow. I'm the first year gynecologic oncology fellow here at Mass General. Thank you everyone for taking the time to share your cases with us and let us learn from you. My talk is not about ovarian cancer, but it is about immunotherapy in cervical cancer, which is something that's pretty new, even here in the States. And so I thought I would just sort of go through some of the different trials and recommendations for immunotherapy in advanced cervical cancer. So just in terms of the timeline for when we've introduced new drugs for the treatment of metastatic cervical cancer, before 1999, patients were given single agent cisplatin for any patient that had greater than stage 4A cervical cancer. And after GOG 169, patients began to receive cisplatin and paclitaxel as a double agent regimen. And in 2004, cisplatin paclitaxel was then compared to multiple doublet regimens, including gemcitabine and cisplatin, as well as vinorelbine and cisplatin. And cisplatin paclitaxel was still, or those regimens were found to be non-superior to cisplatin paclitaxel, so that remained the standard of care. And then in 2004, GOG 240, that's not true, not 2004, 2014, GOG 240 compared platinum paclitaxel to platinum paclitaxel and bevacizumab, and showed that the addition of bevacizumab did have superior outcomes. So bevacizumab was then added to the regimen, and then subsequently in GOG or in 2015, JGOG 0505 showed that carboplatin paclitaxel was non-inferior to cisplatin paclitaxel with a better side effect profile. So that is largely what we use now, although we do still use cisplatin in patients that have perhaps never seen cisplatin before, for example, if they are recurrent. And then immunotherapy sort of came into the field, and Keynote 158 is the sort of at least one of the trials that made pembrolizumab FDA approved for the treatment of metastatic recurrent cervical cancer after first-line treatment. There was shown to be anti-tumor activity with pembrolizumab. And then shortly thereafter, in the fall of this year, was published Keynote 826, which was a randomized controlled trial, which we'll get into shortly, that led to the approval of pembro being added to platinum, paclitaxel, and bevacizumab in the upfront setting for persistent, recurrent, or metastatic cervical cancer. By upfront, I sort of mean, I guess, first line. So what I want to talk about today is there are lots of different sort of categories of immunotherapy and different types of therapy, but today I thought I would talk briefly about immune checkpoint inhibitors, specifically PD-1 and PD-L1 inhibitors and CTLA-4 inhibitors. So PD-1 inhibitors, program Death-1 is a protein that is an immune checkpoint receptor that binds to the PD-L1 receptor on either tumor cells or also just regular cells within the body to downregulate T cell activation. So in healthy cells, PD-1 will prevent the T cell activation from attacking cells that are our own and that are healthy, and it promotes self-tolerance and sort of prevents autoimmune diseases. But in cancer cells, PD-1 allows these cells to escape T cell destruction and continue proliferation. And this is especially, PD-1 is especially thought to play a role in the persistence of HPV infection, which, as we all know, is one of the main causes, or is the main cause of cervical cancer. And it provides an excellent target in cervical cancer for drugs. So pembrolizumab is a monoclonal antibody that blocks the PD-1 receptor expressed on T cells. So those T cells cannot be downregulated and can thus attack tumor cells. And Keynote 158, as I had mentioned, was tested pembrolizumab in recurrent refractory cervical cancer. This looked at multiple different solid tumor types, and specifically this paper looks at 98 patients with cervical cancer. And the response rate was 14.6%, which doesn't sound very high, but the disease control rate, meaning anybody who benefited both in response or stable disease, was 33%. So this is very promising in patients that are recurrent and have already seen first-line treatment. And the median duration of response, so those who did respond, they had a very long response. And so that's really important to remember. And specifically, it led to the approval in our country of pembrolizumab use in patients that on IHC were PD-L1 positive, or on immunohistochemistry were PD-L1 positive. And then subsequently, pembrolizumab was tested in patients that had not seen any treatment before for their cervical cancer in a randomized controlled trial. And it was added to the standard of care, and the progression-free survival in our PD-L1 positive patients was found to be 10.4 months compared to 8.2 months in the control arm. And as you can see, here, there was a benefit sort of for overall survival as well. The median overall survival had not yet been reached, and the hazard ratio for death is significantly less when pembrolizumab was added. So this also led to the FDA approval in the upfront setting for cervical cancer as well. Then just briefly, another type of immune checkpoint inhibitor is CTLA-4. This is a cytotoxic T lymphocyte associate protein, which is expressed on T cells and T regulatory cells. And this also mediates immunosuppression in a similar way to PD-L1 or PD-1. And so again, it allows sort of T cells in the normal setting to be downregulated so as not to attack our healthy cells. And in tumors, it allows them to escape the immunosurveillance. So Checkmate 358 is a study, one part of which has been published, and another part, an interim analysis has been presented. And this looks at nivolumab, which is another PD-1 inhibitor, combined with ipilimumab, which is a CTLA-4 inhibitor. Just briefly, the monotherapy of nivolumab only did show good activity in cervical cancer. And then in the combination of the two, we saw an even more synergistic effect where the response rate ranged from 23.1% to 45.8%, which doubles the response rate of that single agent pembrolizumab at the very least. Remember, it was 14% and it's now much, much higher. So this is being used not in the upfront setting, but in the second line setting for recurrent cervical cancer, though the final results have not been published. And you can see here again that duration of response is pretty prolonged for these patients. These, there were 5 responses, and 3 of them, as you can see, continue to have a response at 120 weeks, so over 2 years. So this is just very briefly a table that looks at the different sort of trials and outcomes of immunotherapy, and specifically immune checkpoint inhibitors. And we can see sort of a variation in the objective response, but all of these are fairly promising and certainly are better than our standard cytotoxic regimens for these recurrent patients. And this just looks at these are our NCCN guidelines, and you can see here that pembrolizumab is approved in the first line therapy setting, and then pembrolizumab and nivolumab are approved in the second line, as well as tisotumab, which we won't talk about today. And just I want to briefly talk about immune-related adverse events. So while these therapies are sort of less toxic than chemotherapies in a lot of ways, less nausea and vomiting, for example, less hair loss, there are some other adverse events that can be pretty significant. So in clinical trials, 10 to 30% of patients develop grade 3 or more immune-related adverse events. And this can be anything from hypothyroidism and adrenal insufficiency to encephalitis, pneumonitis, and these are some of the most common ones. And we have a really great practice guideline that looks at, it's over 60 pages on how to manage those. But certainly these are events that we're still learning about and are quite new for us and for our patients. So just briefly, pembrolizumab is approved in the US in the upfront setting and in the recurrent setting for advanced cervical cancer. Nivolumab can also be used in the recurrent setting. And the nivolumab ipilimumab combination is quite promising, though we don't have the final results from that study. And there are many other types of immunotherapies and immune checkpoint inhibitors that are showing some promising early results, especially in the early phase studies. And immune-related adverse events can be frequent but manageable. I think that I did that in about 10 minutes, but if anybody has any questions or is interested in the slides, I'm happy to send them along as well.
Thank you so much. And I think that was amazing. And I realize that the access to immunotherapy is perhaps challenging in Bangladesh. However, I would say that there is a very robust pharmaceutical industry in Bangladesh, and a lot of products in cancer care are made actually locally in Bangladesh. Isn't that right, Kamal? So, I mean, maybe something for the future that is affordable in Bangladesh. I wanted to thank everybody and maybe bring it back to Dr. Kamal to close the session. And Dr. Farhana, thank you so much for your brilliant cases. Dr. Aliva, Dr. Devins, thank you for your comments. Dr. Tom and Alex and Lauren also. Thank you.
So thank you, AK. It was, as I mentioned at the beginning, I'm proud to be a part of history that has been created today with the collaboration of MGH, and as usual, AK is the instrumental. And thanks to all the colleagues from MGH. Marcella is not yet here, but we were honored to listen to her at the beginning. And Tom, as usual, you proved again that you are a great friend. And the pathology colleagues, we learned so many things from you. I mean, most important, how we should think. This interaction is to change our thought process. We need to understand how you people are thinking transatlantic, so that we can borrow the idea and then we can combine it together. And I'm so grateful to Dr. Barkov for teaching us that, showing some more hope to the metastatic cervical cancer, because as AK said, in our country, yes, was there any comment from, yes?
Yeah, I just wanted to ask you, Kamal, are there pathologists in this meeting, in this session?
From Bangladesh?
I can assure
From
you
Bangladesh?
from next session, I will ensure, probably today not, but I will ensure.
That would be lovely, you know, that would be really lovely, because then we can actually bring it all together and we all can learn together, you know?
I will ensure. So Barkov, I will say that it was a wonderful presentation showing more hope to the cervical cancer patients, because yes, it is not always possible, but you know, in our country, some of the patients, they try to use their last penny to buy some hope. So for them, yes, Pembro is a great hope for metastatic. And by the way, AK, you will be happy to know that Rupinder from India, a senior gynae-oncologist and the secretary of their society, she joined us. We are so grateful to you, Rupinder, for supporting us. This type of encouragement is helping us to go forward. Thanks, Rupinder, for joining. And I see many seniors from my country, and other than the faculties from USA, I see some of the colleagues also joined. Maybe we will be knowing them in course of time. Today, I'm so sorry that Shahana could not join. Even this is her brainchild. It was her baby, but we are nursing it today. We wish that next time we will be enjoying the presence of Shahana, and this interaction will be helpful so that we learn from each other, we share the experiences. And the last thing is, we need to give the best care to our patients, because we believe that there is a boundary, there is a geography, but knowledge should not be blocked by the boundary, and every patient in the whole world deserves the best. So at least we should offer them the best, whether they can afford it or not, that is the second issue. In the name of limitation, we should not block our thought. Yes,
Dr. Sekhon.
Yes, Rupinder. You like to say something? Yes, Rupinder.
Thank you so much. I have enjoyed both the presentations immensely, and I'm so happy to know that we are doing almost the same thing as what our friends in Boston are doing and what our friends in Bangladesh are doing. Thank you so much, Kamal. Pleasure was all mine. And thanks, AK. Pleasure to see you again.
So, AK, I think we can finish it. I know you people will be rushing to your hospital time. Thanks for sacrificing the pre-hospital time with us. And we will be taking this advantage, not very frequently, but quite regularly. And we hope that we'll be seeing you all the faces there and some new friends. We'll be making new friends, learning new things, and we will be combinedly taking care of our patient. Thank you very much.